perhaps we can get started. It's been a long day, and but it's been a very enjoyable day from my perspective, and I'd like to take the opportunity to thank everyone again for coming and for staying here and hanging in till the very end. And to get the discussion going, what I'd like to do is sort of ask questions of individuals and see if we can get some interaction going, in particular to ask Ed and Avi. They both talked about the genetics of COPD in a different way, Avi with the gene expression and Ed with more attention to the DNA and looking for the various sites in the genome where they might be active. Now, is there any chance for interaction and leverage between those two approaches?
Oh, absolutely. I mean, certainly from looking for expression quantitative trait loci, as investigators here are doing for genetic determinants of the expression levels, but we've also been interested in genetic determinants of potential biomarker proteins, genetic determinants of DNA methylation, genetic determinants of metabolites. I think that we need to view these various omics platforms as different ways of looking at a very complex problem. And each can give us a slightly different perspective, and if we can understand how those factors relate to each other, it can give us even more potential insight, but it's complicated.
Yeah, no, I completely agree with that, and I think that's how these EQTL studies are coming, and the other thing I'd add to that is, I think what we haven't yet seen in COPD, or I said lung cancer is so far advanced, is looking for somatic mutations, driving events. So the stuff looking at hereditary predisposition is obviously very important. What I think we need to be doing also in lung tissue for folks with COPD is looking for somatic mutations that may be part of the disease process and that can be potentially targeted with agents. And I know there's some efforts now to sequence DNA within lung tissue from COPD patients, but I haven't seen very much out there. Yeah. I don't throw that in. For some reason, that isn't a space that people are going after, and I think it's a missed opportunity.
Yeah, frankly, I was always skeptical that somatic mutations were going to be very important in COPD. I think it was my own biases. And certainly in malignancy, where something fundamentally goes wrong in the genome and cellular transformation occurs, it certainly made great sense to try to find those genetic drivers of cancer. But there are certainly some pulmonary diseases, like pulmonary arterial hypertension, that have sort of malignant-like features, LAM, I think, as well. I guess I didn't used to think of COPD in those same terms, but I think it's certainly worth investigating. Are there changes in the airway cell DNA or the epithelial cells DNA? I think it's worth investigating. I wouldn't bet my life on it, but I think it's worth looking at.
Right. And again, I sort of see COPD a little differently. I come from the cancer space, and I see COPD as a pre-malignant condition. I view it as sort of, and that's why I do think there's a chance there would be early mutations in the airway and lung of folks, probably the more severe COPD, who are at the very high risk for lung cancer. And whether those mutations play a role in their COPD disease is an open question. But it's something I think that should be explored.
Now, how about from the audience?
Well, I was on the same line. I was just wondering, neither of you mentioned epigenetic changes, and I wondered if you see that as another avenue to look for genetic or genomic changes.
Yeah, no, 100%. We, in fact, I ran into someone during the break. We had actually done some methylation profiling of Jim's lung tissue specimens years ago, and begun to correlate gene expression with methylation events within the same specimen, similar to what I showed with the microRNA. And I think there's been so little done in that space. I know Don DeMeo is doing a lot of really good work with Ed in this space. I absolutely think the epigenome is understudied in this disease, highly understudied. And I think it's an important regulator of these gene expression changes.
I think that the real challenge with epigenetics is moving beyond DNA methylation to look at things like histone acetylation at a genome-wide level. It's been harder to do that. We don't quite have the platforms readily available, but it's got to be important. If there's going to be any disease that's going to be important for epigenetics, you probably put COPD at the top of the list as a way to transduce the environmental effects onto the genome.
Questions from the audience on this topic, or any other that came up?
Peter
wants to say something. Oh, Peter, sorry.
I don't want to say anything. It's a general issue about the appropriateness of controls. And, we still don't know, despite all your efforts, why only 20% or so of smokers get COPD. 80% don't, although some of those maybe, but there are some that clearly don't get it despite huge exposure. And so it would be interesting to know how the exposure is related to gene expression, because there must be some people who have protective genes, and in COPD something's gone wrong.
Yeah, no, I think that the two extremes, that we focus on for our early whole exome sequencing studies have been people with severe COPD at a very young age with lots of emphysema, sort of trying to find another alpha-1. But on the other end of the spectrum, the controls have been the oldest people that we've got who have smoked the most and who have no emphysema at all and have completely normal lung function. And at least in the first look at the whole exome sequencing analysis, we find as many rare variant signals in those resistant smokers as we do in the susceptible COPD subjects. I think there certainly could be something important about those individuals.
Questions? Yes.
Question for Dr. Barnes. I thought there was a contradiction in your speech. In one hand, steroids are not effective in COPD in those patients, and yet medications that make them steroid sensitive, like theophylline, are helpful. How do you?
Well, that's exactly what I said, because steroids don't work as they are, except if you've got asthma as well, or a combination. But we've been looking at why they don't work. I mean, why are they not switching off inflammatory genes as they do in asthmatics? I mean, almost all asthmatics respond to steroids. And we think it's linked to this PI3 kinase HDAC pathway. So the point of giving theophylline is to reverse that block. And so then steroids should become effective, as they are in cells. So if we take a COPD macrophage that is complete, the dose response to steroids are way to the right. So you have to give very high concentrations to inhibit inflammatory mediators. And we then give these cells theophylline, then you can shift the dose response curve to the steroid. So then you can use lower doses. I think we all accept that low dose inhaled steroids are safe. What is dangerous is high-dose inhaled steroids, particularly fluticasone, because of the systemic absorption and maybe local immune effects. But we know that low doses are fairly safe. And in the Sami Suisa study, there was a dose response to steroids. And the problem is that all of the clinical trials in COPD, or pretty much all of them, were done with high-dose steroids. And so it's the high dose that have the approval for administration to COPD. But I mean, either they should be on no steroids or they should be on a low dose of budesonide, because we know that budesonide is less likely than fluticasone. So I think we could already change our clinical practice. And we have to do trials. We can't go and recommend theophylline until we've done clinical trials. And I talked about these 2 trials that we're just starting. But it takes time to get evidence, because you can't change the guidelines unless you have evidence. I mean, I believe in theophylline, but I can't recommend it because we don't have evidence. And the problem is the cost of studies. I mean, the TORCH study that I referred to, that has 6,000 patients studied for 3 years, cost $60 million. No, sorry, $600 million. $600 million, which is half of the budget of the UKRC. So how can academics afford to do those studies? I mean, they can't. You have to do it with drug companies, and drug companies don't want to promote cheap drugs. Why would they?
Dennis?
In the spirit of provocation, when I asked Don, he might have, wondering if he has a different view on the role of steroids, because I think you've told us that it may have some beneficial effects on systemic inflammation. And there's a school of thought that believes that there are positive effects on vascular function. Do you still believe that? And do you need high dosages to achieve that if it's there? And do you disagree with Dr. Barnes beside you?
That's the real question. I wouldn't dare disagree with the professor. Although I was curious, I think Iqbal said there was or Vidi said there was, Dr. Barnes had one contradictory statement. his entire lecture was contradictory. So that's just a preface. I think my thinking has evolved in this area, or devolved, depending on how you look at this. Now, when we did the fluticasone salmeterol study to look at systemic inflammatory parameters, and indeed, if you look at surfactant protein D as one of the biomarkers, it does reduce it on average. But what we noted in post-hoc analysis was that only about 20% experienced this decrement in surfactant protein D in their blood within this 4-week window that patients were exposed to. And this is the group that had the biggest increase in their FEV1 during that relatively short period of time of exposure. They experienced the greatest improvement in health status. Now, we didn't carry on that study long enough to look at other hard outcomes. So whether they represent the asthmatic phenotype, which I highly doubt, I think there is a endotype. I think the molecular processes that drive COPD differ across certain patient groups. And I think steroids have a role in a particular endotype. What that is exactly is uncertain. Maybe some of the genetics and genomics studies would provide answers to that. But, you know, in our crude hands, using surfactant protein D as a biomarker of lung inflammation, there was about a 20% response in those treated with steroids. And so I do believe that in that particular patient population, steroids have a role. I also believe what Peter said is that we're way over-treating people with steroids, particularly in very high doses. And the pneumonia signal is real. And there are very few things that I agree with, not only Dr. Barnes, but Dr. Suissa. And he and I both agree that high-dose steroids in COPD are a bad idea.
There's a question at the back.
Yeah, I just want to continue with the steroid idea. What do I do now when I go back to the hospital? Just about every patient I see is on inhaled steroids. How do you go about which ones come off?
Will you take them off? It's not difficult to do.
Coffee.
But you don't want to stop it suddenly, because this is bad, because they're having a big systemic effect. They've got adrenal suppression if they're on fluticasone, and it's like adrenal withdrawal syndrome. They get very tired and they feel ill, and that's often counted as an exacerbation, which is why the trials are all flawed, where they take people into the trial already on steroids, because the placebo group gets stopped suddenly. And what you can do, which has been shown by Helga Magnussen's study, is that you can safely withdraw steroids by cutting the dose gradually. So you halve the dose, see how they go for about a month or so, then you halve it again, and if they're okay, you can stop it. And you have to just see how they go. And I think almost all the patients in his study came off steroids, and it didn't make any difference to their exacerbations. So you can stop inhaled steroids, and the fact that we now have these more effective bronchodilators means that you probably should, because as I showed you, tiotropium is just as effective as giving Seretide, but it doesn't cause pneumonia. It's very well tolerated. In fact, it reduces overall mortality, including cardiovascular mortality. So, you know, you should certainly be making sure they're on a LAMA, but then you can add a LABA. And indicaterol is the one that's available so far, and it's been shown that indicaterol and tiotropium have additive effects. And this will be better than a steroid. And it's now been shown that QVA 149, Ultibro, is more effective than Seretide. So it actually works better than Seretide.
Peter, to be fair, I think you're being very selective in your quotation.
Well, I'm quoting the literature.
Selectively. There are studies showing that combination of inhaled steroids and long-acting beta-2 agonists do, in fact, reduce the risk of hospitalizations, the more severe exacerbations in COPD. And in the study that you quoted, Uisha study, there was a mortality signal in favor of the combination arm. And the health status of the patients were reported to be better when they were on combination. So while I don't fully disagree with what Dr. Barnes says, how could I? I think you're being a bit selective.
Well, I'm looking at the evidence as I see it.
Are there other comments? Yes, a question there.
Yes, this will be completely an uncontroversial statement that Dr. Barnes made earlier this morning about the largest risk factor for COPD, bigger than smoking, is poverty. And there are very low side effects to poverty reduction. What are the examples? There are some examples of interventions to reduce poverty. The Swiss, for example, are on a quest at the moment where everybody is, I guess, getting a $10,000 bonus. Are you familiar with any of these intervention trials? And is anybody looking at COPD effects or even other chronic diseases in a poverty reduction intervention trial?
Well, I'm not aware of specific studies, but I think what we need to understand is the elements of poverty that are the risk. I mean, I think poor diet is one, but it's very difficult to measure that, and dietary intervention studies are very complex. So I just think there's a need for more research. But there may be other things. So people in damp houses are more exposed to fungal spores, which are now seen as a risk factor for COPD exacerbations. They're more likely to live near motorways and exposed to diesel particulates. So poverty comes with a lot of things that go together. And what's been shown in studies of non-smoking COPD is that there's a marked interaction between these risk factors. So passive smoking, exposure to passive cigarette smoke, environmental tobacco smoke, markedly increases the risk of biomass exposure for COPD. So that probably these are interactive factors. But some of it's related to education. We know that poor people eat bad food not just because they don't have money, but because they're used to eating bad food, like hamburgers, because they're convenient. But actually, they could buy food that's healthy, fresh fruit and vegetables, at no additional cost, but they're not educated to do that. So it's really, there's a big educational issue as well in lifestyle that needs to be looked into. But I think it's quite complex. But I think it's the sort of thing that economists should analyse, because if you think of the healthcare costs that Mark referred to this morning, these are absolutely enormous for COPD. And so investing in this, or giving people money, as you indicate, might be cost effective, because it would stop these diseases and the comorbidities that go with COPD.
So there are no hospitals in Switzerland?
Well, in Switzerland they're very rich, but they have
hospitals.
No, but they have cardiovascular disease. The rich people have cardiovascular disease.
Oh, I see.
And poor people have COPD.
I have a question for Peter. Mark de Kramer's not here, but several years ago he conducted the Bronchus Study, which looked at N-acetylcysteine versus placebo as to reduce exacerbations in COPD, and unfortunately it was a negative study. But in their post-hoc analysis, they found a signal in patients not taking inhaled steroids. So how do you interpret that study? NAC we consider it to be an antioxidant, among other things.
Well, yeah, I don't know how to interpret it, but it's confirmed by the study in China with carbocysteine, which works in pretty much the same way, and they were not on inhaled steroids, and they found some benefit. So there may be some benefit of these antioxidants, and maybe it's masked in some way by steroids.
But according to your paradigm, antioxidants would enhance the HDAC pathway.
Yeah, but I can't explain that observation. But N-acetylcysteine and carbocysteine are very poor antioxidants because they don't neutralize oxidative stress very effectively, because oxidants inactivate the molecules. So you could, if you have a low level of oxidative stress, you could reduce that. But if you have a high level of oxidative stress, as we believe to occur in the lungs, it will not be sufficient. which is why people are looking for more potent antioxidants. And why they're looking in particular for NRF2 activators, because it seems that the NRF2 system is not appropriately responding. So if you look at normal smokers, they have very high NRF2 activation, which is what you'd expect because they're exposed to oxidative stress in cigarette. And that's what you want, because you don't want oxidative stress to damage the cells and cause cancer. So it's our defense against the damaging effects. And that's why they're normal. But for some reason we don't understand, the COPD patients don't increase NRF2 in response to oxidative stress. And we think that's partly related to the fact the NRF2 protein becomes acetylated. And we've shown that acetylated NRF2 is not very good at switching on antioxidant genes. So it loses its transactivating potency.
There's a question over here.
I think this was asked this morning, but I wondered if there's any more comment this afternoon. If there is a strong genetic basis to the development of COPD and particularly emphysema, how does that explain the differences in the types of emphysema that we saw? Is there any sort of, I know there's no real explanation, but is there a theory as to how you can get that range of disease expression with what should be common gene pathways?
Well, and we don't know that they're common gene pathways. And I think that our hypothesis, which has not been proven, is that those different pathologic patterns represent different biological pathways that are potentially related to different underlying genetic susceptibility and potentially different epigenetic responses as well, which lead to different gene expression signatures, and that they may be fundamentally different diseases that just get grouped under the COPD umbrella because people get airflow obstruction, eventually as part of the process. So I would say that until proven otherwise, I find it hard to believe that all those widely different patterns of pathology are caused by the same biological process.
Yeah, I just want to make a comment about. I mean, I love the idea that about disease heterogeneity and dividing these COPD up into smaller and smaller groups, especially if it's based on biology. But then I worry that, the real therapy would be one that hits the common final pathway. And if we divide the disease up into smaller and smaller subgroups, and then we try to go and find specific therapies and get drug companies to do a study on the 7% who have this interstitial pattern on the CT scan, I just worry that maybe we should be looking at the final common pathway and something, the magic bullet, like statins, Otherwise,
No, I think it's a really important question. This is something we struggle with all the time, and the pharma industry struggles with this. And lung cancer is a great example now, where it's being divided into a million different very small diseases, a specific fusion event or a specific EGFR mutation. And a very small fraction of folks get a drug. Pharmaceutical company charges a ton for that drug. They still think there's enough of a market with the size of lung cancer. I agree, if you get into too small of a bin, it becomes a problem. But I think the idea that there's a magic bullet is probably not true it's not true for lung cancer. I don't think it'll be true for COPD. I agree with what Ed said. I think there's probably many different molecular pathways that lead to these different radiographic or clinical phenotypes. I would add to that, even the same clinical or radiographic phenotype probably has multiple different molecular pathways to get there. And so I think the endotype, the word that Don used, is really the key. I think we need phenotypes of disease that are mechanistically based to go after. And the bins are going to get small. I don't think they have to get too small to keep that. I would argue there is still enough of a marketplace, even if 10% of COPDers have a particular endotype, that pharma would get involved to target that endotype.
I think the concern is that if you were going to target something that really was the final common pathway, there would have to be something that was so disruptive of cellular processes that would have huge side effects, like systemic steroids or worse.
Right. Okay.
But I mean, inhaled steroids are very effective for most people with asthma. I mean, if someone...
So there is some common in asthma.
Yeah. Well, I mean, that means there should be something in COPD.
But there might be.
But the problem, I think, that could also occur is that you may change pathways as the disease evolves.
Sure. Right.
and that one pathway then leads to another. And we know that these kinases are regulating each other, which is why blocking P38 fails eventually, because you just get these escape pathways, just as you do in cancer.
No, lung cancer is the same thing.
It's the same thing.
You have a clinical response.
And you see this with the leukemia, Gleevec.
Correct.
Is they get escape pathways. And so the pharmaceutical industry has been trying to find very specific kinase inhibitors. But actually what you want is non-specific inhibitors, like these drugs developed for renal cancer and things that have a very broad spectrum of kinase. And one of the drugs that the Respivir company developed was a limited selectivity kinase. So it inhibited several pathways. And it turned out that it inhibited the pathway that was the initial one that they wanted to inhibit, which was a P38 pathway. But it also inhibited the escape pathways. So it didn't lose its effect. And that drug is also in phase 2 now. So I think we have to look, and that's the approach in cancer, isn't it? Is that you use broad spectrum kinase inhibitors.
Broad spectrum or
which would be dangerous orally, but you can think of giving them by inhalation.
Right. No, the idea of combining different targeted agents in the same patient, I mean, that's where it's worked in HIV, it's worked in several cancers, and lung cancer, that's where the field is heading for exactly that reason.
So it works in tuberculosis too.
And TB, yeah.
Well, I think on that note, we'll bring this to a close. And I'd like to close first by thanking the organizers, particularly Paul Mann, who I think has gone off to look after patients, and Don Sin, who did the yeoman's work of organizing this seminar. And I'd like to thank the Gairdner Foundation. I'm deeply sorry that John Dirks wasn't able to join us. He did something to his back and is laid up and couldn't face the plane ride out of here, but it was his idea from the Gairdner Foundation to have this symposium in the first place, and he's the one who provided the initial stimulus to have it. And it's a pity that somebody from the Gairdner Foundation couldn't be here, but that's just the way it turned out. And finally, I'd like to thank everyone for coming, particularly the speakers who came long distances in many ways under difficult travel circumstances, and have arrived safely here in Vancouver, and it's been a pleasure to see you all. And in closing, I'd like to finally thank all of the participants for coming here and spending a long day, really, especially those of you, the hardy souls who've stayed through the whole thing. And good night to everybody, and good luck to everyone. Thank you.